Can't hear. Why can't I hear you?
Hello.
Oh, there we go. Okay.
Now, is today your first day of work?
Yeah. Tomorrow.
Tomorrow? Okay. So I had the 14th in my head, but I guess the 14th was your last day prior. So 15th.
That's the day you give condolences.
I know. I'm worried about you. How you feeling?
You know what? It's that actually doesn't matter. Because it's head down, push hard time. So it's like it doesn't. I'm ready for that.
No, you are. Just pace yourself. Pace yourself.
Yeah. I mean, it's gonna look like everything's fine, but yeah, I gotta put my head down and just push hard and get through every day, adjust, react. It's gonna be fine. But I'm gonna go shave this stuff off my face real fast.
If you want, we have time. I just wanted to make sure they didn't jump on or he didn't jump on and we weren't here. He'll probably, now that he got in last time, it's probably close. Although I'm not sure. I don't know that we have a lot of crossover from Saturday, which is good. So we can have a rerun of questions and it won't feel like a rerun.
Good. Dave Lemer texted me. Mm-hmm. And what did he say? Anyways, I said, we decided to discontinue the Tuesday calls. Mm-hmm. And he said, well, yeah. I said, I was going to call you. I forgot to call you, but we decided, with the resources and everything going on, that's the right thing to do. Mm-hmm. And he said, well, yeah, I would have appreciated a phone call for that, but no problem.
Oh, well, ditto for other stuff. Here comes Dr. Logie.
Yeah. You got him? Okay. Yep.
So, all right. Hi, Dr. Logie. Oh, we've got you on mute.
Oh, yep.
Okay. Yeah, I had trouble joining today.
Really? Oh, I'm glad you practiced early then.
Well, that's why I figured I better start. But it routed me through the app, and it was going to let me correct my name. It never lets me correct my name, but it won't let me. It forces me to look at the stuff you're supposed to agree to, but there's no agree button. And it won't let me join. So I don't know. I went to your second link and that worked.
Okay, thank you.
The first one should have worked.
I think Zoom sent out maybe some widespread update because a few other Zoom calls I've been on, there's been a delay because of updates, and the people that are used to just clicking the link can't click on the link anymore if they don't have a Zoom account. And
I wonder if that's what it is.
All that.
Yeah, because it re-edited my name months ago, and when I actually use it, it doesn't. I don't know where to go back to actually properly edit it. It's normally the editing process is as you open up at the beginning, but I've not been able to go through that process and actually then successfully link to a meeting. That's why I say I was planning to put together a surgical oncology conference, but I just couldn't see doing a 5.5 hour meeting that we would have to do by Zoom, because we'll have multiple speakers broadcast to different areas and videotaped. And with that much going on, I mean, just with our 1 hour meetings, we typically run into technical issues.
Yeah.
So it's and to be honest with you, I don't want to organize a 4 or 5 hour Zoom meeting.
No, that's too much work.
Yeah, it is.
Yeah. Well, it's too much stress because, to your point, you're worrying about everything working. The internet has to be stable and everybody has to access. So I agree.
And they typically don't have IT people, bird dog that kind of stuff. They expect you to sort of do that. So to be the organizer and then feel responsible for everybody connecting, but when I'm not IT, is a little hard. So we'll see. Any particular topics for today?
It's really more of the same. So I think we have similar questions to the last time, let's see, the new questions, came in, maybe talking a little more, okay, patients usually are so lost, probably not with your patients, but when they have their surgery and then they go off on their way, and a lot of it's trial and error, whether it be diet, the follow-up, that sort of thing. And so if you could give your thoughts on what they should do post CRS HIPEC. We had a question, also another question came in. It was interesting. This is from, and I don't know if they'll be on, this is from a medical oncology center in Kansas. And the question was for patients that have had systemic chemo prior to surgery, had CRS HIPEC, end result was good, clear margins. What would the protocol be for systemic chemo post surgery? So that was a question. And turmeric by far is your number one question.
Okay.
So I can, one of our other team members is actually a patient of yours, and I was Misty Price.
Sure.
And she's on, so I was going to let her in momentarily, but I just wanted to give you the heads up.
Sure.
Okay. Hi, Misty. Oh, you're on mute too.
Hi there. How are you?
Good, thanks.
I just recently registered. For some reason, I don't seem to get the emails. So I registered just a minute ago and I put a question in there.
Okay, thank you. Don't know what's going on. So yeah, I let you in early, Misty, but we've got Dr. Logie's here already, and Chris is on.
But he's not there.
Yeah, no, he's here. Yeah, no, he's here. I don't know if you can see. Can you not see him?
I can see his empty chair.
Oh no, that's Chris.
Yeah.
Dr. Logie's here though.
Yes, I can see Dr. Logie. How are
Okay.
you, Dr. Logie? I'm so sad that he is leaving us. I'm not pleased.
Oh, Dr. Logie, I have to tell you, we have had so many of your patients comment on our Facebook post when we were publicizing that you were speaking, and I can send you all the names, but hands down, everyone, that man saved my life.
Mhm.
One of the best surgeons out there, but nothing but compliments for you.
Well, thank you. That's very sweet. Yeah, I mean, I've been doing that since, was it December 1993, or was it 22? I know it's 20 years today. So this is 21. So I guess it was 91.
Wow. Today is the exact day, 20 years? Or
It was somewhere between Christmas and New Year. I've got the date on a picture, but the picture is in a box. And I don't remember whether, I think the box is, yeah, I know where the box is. It's down at one of my studios downtown.
oh my
And
goodness.
yeah, so I didn't realize I had it all that time. I found the picture and it was dated on the back, but my partner Ed Levine had told me as well that this was the 20th anniversary of cytoreductive surgery HIPEC at Wake Forest.
That's
So.
amazing. But it's a long time, but it's not. It's kind of sobering to think of, we patients, if we have to get diagnosed, that we're diagnosed at a time where we have specialists that can treat us.
Yeah. Oh, yeah. And some of
Hi,
us
Jamie. Hi.
some of us still have internists who say, "Oh, but that's experimental."
Oh my goodness.
That's going to go on for a while.
He hasn't said it lately since I got right in his face and I said, "It is the standard of care." I haven't heard anything more from him about it.
Well, that's good. That was the hardest slog. I really thought once we showed our survival data that the medical oncologist would jump on board and would be interested in working with us. But a lot of medical oncologists remain skeptical and closed-minded. Reminds me of some other stuff going on in society these days.
Yes.
For sure. Oh.
So, and then I don't know if people are interested in talking about diet or nutrition as well.
Yes,
Yes.
yes.
Definitely.
One of our top topics.
Always.
Yeah, now going forward, if there's interest, I cannot comment on specific cases because I don't, I'm going to keep my license for a while, but I'm not in practice, so I don't have malpractice insurance. So I can't do consults in that way, but I would be able to talk about diet and nutrition to more depths, because honestly, that really would take at least a webinar.
That would be tremendous.
Yeah. Those
So
are big
maybe we can
topics.
think about that in the new year.
Okay, it's a plan.
Okay.
And Dr. Logie, your ideas on this have morphed in the last few years, have they not?
Yes, they have
Okay.
So
quite a
I
lot.
don't know if all of you can see my chat, but I just got an update from Harold that Sherry is finally off of TPN and they
Oh, thank
removed her
goodness.
PIC line yesterday.
Oh, that's good news.
awesome.
So my
That's great
Grinch
news.
heart grew today.
Thank you, Jamie. It's exciting.
This individual, yeah, I'm so happy to hear that.
Has she been on a PIC line and TPN all this time?
Yeah, yeah. She was discharged, then had to go back in because of her nutrition. And then, with her being immunocompromised didn't help. So she's been on the TPN. They tried to wean her off and it didn't work, so they had to keep her on it.
Mm.
All that happens.
Oh, hi, Spock.
There's Spock.
We have a mascot. We have a few
So
mascots.
cute.
Oh.
So
I made
Connie
masks.
and Charmaine, do you guys see the waiting room?
No,
Oh man, I see it, Chris. The
Okay.
admit or admit all.
Wait a minute,
Right.
hold on. I'm in the wrong thing. Let me get there. Oh, I do.
Yeah, so we have about 25 that registered for today, Dr. Logie, but
Wow.
right now we have about, at 10, 11 and counting, so.
Yeah. I mean, if you want to hit the admit all button, you'll get the thrill of doing it. And then Jamie, if you want to watch and just let people in.
Yeah.
look-
Okay, I'm doing it. I'm
All
clicking
right.
the button. Yay.
Let's do it. We're ready. There's no better time than now. Hello, everyone. Hi. Welcome to the PNP Pals Hope Zoom call. We will give everybody a chance to get in and get settled, and we're glad to see everyone. And of course, we are here today with Dr. Brian Logie. Again, we had him on Saturday. We were really fortunate to have his great insight and advice then, and we get him again today. So it's good times for sure.
Hey, you're welcome. Glad to be
Thanks
on.
Thanks for being here. Yeah. I don't know how the weather is for everybody else, but it is cold and rainy today here in San Diego. It is really, it's messy, to be honest. So, but it's great to see everybody. I see lots of new faces and old faces.
yeah, I see a longtime pal, Mark Townsend. I recognize that name. Hi, Mark. Welcome.
Hi, Mark.
Yeah, I had to get on this for Dr. Logie's final hurrah.
So glad you could join us.
He treated me 11 years ago, and I've been cancer-free ever since. I've done a lot of good things since then.
Fantastic.
Hi, Mark. Nice to hear from you.
Thank you.
Thanks.
We see some hearts, we see some celebrations, some thumbs up there. That's what we like to see. Perfect, Mark. Thanks for sharing. That's fantastic. And while we're getting set, we still have people coming in, and I know that Jamie's clicking away and helping people enter and get settled. So we'll go in just one more minute.
Do I have to keep clicking admit people, Chris?
Yes, you do.
Okay. I'll keep an eye on that.
Yep.
Let me know if I'm missing it.
We're not just having the doctor today. We're having some cross training too. So this is good. Well, I am going to go ahead and kick things off. We are going to go through our introductory slides because I'm seeing new faces today. I will share my screen and we'll jump right into it. And again, thanks to everyone for being here for the PNP Pals Hope Zoom call here on Tuesday. We are lucky, blessed, fortunate to have Dr. Brian Logie from Creighton University here with us today. We had him on Saturday, but the conversation was so good, it's worth repeating again. I see lots of new faces, so I'm excited, and I know you are too. PNP Pals obviously is the world's oldest patient-run volunteer organization helping patients with appendix cancer, as well as the caregivers. So we're glad you're here. We're sorry you have to be here. We're super glad that you found us. Now, here in the Hope Zoom forum, I know that you're going to love the presentation today. Let me go through some of our disclaimers and show you some of the ground rules for how this works. Now, first of all, we are not giving medical advice today. Even though we do have a licensed physician, this is not medical advice. It is essential that you have your own team of licensed, qualified physicians to help you along your journey. So please, we're not giving advice today. We're not having presentations. It's just discussions. And quite frankly, everything we heard on Saturday was really encouraging. So I think you'll find today to be a hopeful and encouraging call today. We cannot guarantee your anonymity. You're welcome to keep your camera off. You're welcome to anonymize your name. It's just technically difficult for some people. And so we just can't guarantee it. That's why we say that. But please, by participating, do understand that your likeness, your health information may be shared with the general public. We are absolutely recording this today. And, so keep that in mind. And this is going to be a popular conversation for sure. So we are going to be recording this. So keep that in mind and decide how much you'd like to participate or not. How do you participate? How does this forum work? Let's talk about that. So this has become very popular, this format. And so with the growth, we have typically tried to check in. Today's a physician webinar, so we're really not going to be going around the table. When we don't have a webinar, we do take the time to check in with each person. It's really a support group and just how are you doing? What questions do you have? So, we can't always get to everyone in that forum, but today we're just going to be talking to the doctor. Please stay here as much or as little as you want. We don't want you to feel like you've got another obligation to be here. So we're here for you. If you've got life to live, a doctor's appointment to go to, just feel free to wave and go ahead and jump off the line. Don't feel obligated to stay. We do encourage you to use the chat function. Put words of encouragement, share your contact information. If you see someone that you connect with, or that their situation is similar, you're welcome to chat with them directly. So feel free to use that functionality. Finally, we'll be doing a hard stop at 1 hour and 30 minutes today with the physician presentation. So keep that in mind. And then finally, we are here on the internet all week long, all year long at pnppals.net, at Facebook at PNP Pals Network, and on Instagram at PNP_pals. So with that, we can start to dive right into the conversation, and Adele's going to lead that conversation with us. We've gotten some questions that have come in, and you're welcome to send others. Feel free to send an email to info@pnppals.net or zoom@pnppals.net. We'll be watching those and answering those questions, and also we'll be looking at the chat function too. So feel free to put your questions in there. And with that, again, I'll turn to our Vice President, Adele Jason, and ask you to lead the discussion with Dr. Logie again. And so take it away.
Okay, well, welcome everybody, and welcome again, Dr. Logie. Definitely appreciate your joining us again for your encore question and answer session. So Dr. Logie is definitely one of the pioneers in our field. And we were talking just before we started, it's about 20 years, it is 20 years in the next few days or so from when Dr. Logie started your first CRS HIPEC program.
Actually, you know what? It's more than that. I just realized it's 30 years.
30 years. Okay.
Yeah, yeah, because it was in the early 19. That's why I said I've got a photograph of the first HIPEC at home, and I told you the wrong date. It's actually 30 years.
Oh, but again, a pioneer, and Dr. Logie, although he is retiring in January, he is currently the professor of surgery, chief of the Division of Surgical Oncology, and the director of the Cancer Center at Creighton University in Omaha. And I'll let Dr. Logie speak, about his background a little more, and then we will start off with what was the most popular question on Saturday. That continues to be the popular question. Dr. Logie is doing some things with turmeric, and is seeing success in low-grade patients. And so, Dr. Logie, I'll kick it over to you.
Okay, well, thank you. I started. It took quite some time to get my protocol for cytoreductive surgery and HIPEC back. The original intent was to treat peritoneal carcinomatosis, and pseudomyxoma is a subset of peritoneal carcinomatosis. It took me a long time, almost a year, to go through IRB, and there were a lot of limitations. But our original operations and whatnot were successful. And so we started accruing more and more patients, and then we're able to start a clinical R01 trial, which went on for 5 years. And what that allowed us to do was to work with closely with scientists so that we could, measure everything much better, collect data much better. And we left a very, very strong and active database at Wake Forest, and the people at Wake Forest continue to use that to everybody's benefit. A disclaimer for the turmeric, and that is that we are using turmeric. We're I shouldn't say prescribing, because you don't need a prescription for turmeric. What we're doing is we're making a recommendation for the dosage, because we think that the active ingredient in turmeric that is helping people is curcumin. Curcumin, less than 4 or 5% of that is absorbed in the GI tract. It's absorbed better if you can combine it with fat or fatty part of your meal. In India, they take that with warm milk to facilitate absorption. And we've been recommending doses, high doses, 3 to 4 grams per day. That's 3,000 to 4,000 milligrams. You can get easily turmeric capsules, either 500 or 1,000 milligrams. So if it's 500, 3 grams is 6 capsules. Obviously, if it's a gram, 3 is 3. And we're recommending 3 to 4. The disclaimer is that it's empiric for right now, but we've been seeing benefit. I've never seen the degree of stability for low-grade PMP. I'm hoping that it will also extend to other conditions, but a lot of the patients that I follow have variations of PMP. So this is the largest group that has been treated for the longest. And it started with patients coming to me that had elected to try turmeric and experimented with the doses. And when they had a couple of people a number of years back who came in that I was shocked that they were showing stability of disease, found out about the turmeric and the dosing. And we started to look at that. And then, because there's no downside that we were able to identify, we started recommending dosages, and those dosages have gone up over time as we've had more experience and witnessed things. But I really wish we'd fallen into this much long ago, because it's going to be, for me, it's going to be an unfinished project. I'm going to try. I have money to pursue it that was given to me by patients, and I'm going to move those funds over to our pharmacologists so that they can pick up the laboratory side of this. What we're hoping to do is to identify, what is an optimal blend or brand of turmeric. Should it be given with anything else? What's the dosage? The other thing is that our pharmacologists think that they can trick it up and make it so it's far better absorbed. So I'm kind of shocked because at the what they're talking about. But the turmeric has a broad anti-inflammatory properties, which is where we started with first, because I published with one of my PhDs, Peter Thomas, and some other people, that if you look at the microenvironment of Pseudomyxoma peritoneae, you see a hugely enhanced activation of inflammation and all kinds of cytokines that are released. And then other factors, for example, CEA is produced in very high quantities in a lot of people that have mucin, and then it escapes into the systemic system, and the inflammatory component escapes into the systemic system. So with more advanced disease, we definitely see a systemic marker of inflammation rise, that is C-reactive protein. So our protocols for monitoring patients with PMP, mesothelioma, and some other diseases includes monitoring C-reactive protein. So that's sort of a thumbnail overview. What we have not seen are any major, I mean, the side effects that we see from turmeric, we don't see any gastrointestinal issues quite typically, but people, if they have aches, pains, arthritis, and whatnot, that tends to go away on the turmeric as well. And of course, the cost is nothing. The other thing about turmeric is that curcumin is that it does, if it gets into the nucleus of cells, it has anti-NF kappa B activity, which is a potentially very important anti-oncologic effect. So that would make it, if true, essentially equivalent to a chemotherapy agent, and but with no side effects and very inexpensive. So I'm pretty excited by our observations. I'd like to be around to ratify them and to then combine them with what we're seeing in the clinic. But I think that for something like this, I'd like other people to take a look at it and try it. And I'd like other doctors to take a look at it and try it, because I think it's almost too good to be true. And that's I'll stop right there and ask for questions.
Yeah, that is fascinating. And a few questions. Can you take turmeric while on FOLFOX or any other type of chemo or drug?
We have not seen any contraindication. It's basically a food, and it's been used for thousands and thousands of years. As I say, you know, sometimes you get GI upset with those. That would apply to everything, not just turmeric. But turmeric we've not seen make that worse.
And on Saturday, we talked a little bit about the form of turmeric, you know, ground, pill, liquid. Is there a preference?
I think for ease of use, then the preference is to get a pre-mixed capsule, because you can buy them very inexpensively at grocery stores, at Trader Joe's, at natural grocers. You can get them online, Amazon. At Trader Joe's, they're 500 milligrams. Other places are typically 500 milligrams, sometimes 1,000. There's no data out there to suggest that one formulation is better than another. A lot of people like adding pepper to it, but we've not been actually able to find proof that does in fact help increase absorption. We can say that it's known that taking it with fat or fatty foods will improve absorption.
How long does a patient need to be taking turmeric to see some results?
I would say that if we're doing something in transition, we will see patients back and follow up a shorter period of time. But I would say, the shortest period we typically see somebody in transition coming back is probably about 3 months, and we typically see stability on turmeric occurring pretty much right away.
Okay. And you mentioned taking it with fat. About how much fat would help with the
Who knows? As I said, I mean, in India, they take it with a glass of warm milk. So I don't know how much fat is in warm milk.
Also on Saturday, you gave us some good insights into diet, and specifically you talked about the hunter-gatherer diet. Could you tell us a little bit more about that and why that is also an anti-inflammatory regimen?
Yeah, let me take, so it comes back to the research that we did, quite a bit of research a number of years back, where we really documented that inflammation is central to the pathology, not only of PMP, but other cancers like mesothelioma, based on our research and what we were seeing. And I became very disappointed with prescription drugs. And the reason that they didn't work, and we used them and we followed patients for a long time, they did help reduce pain and joint pain and whatnot, but they didn't stabilize the disease that we were hoping for. So turmeric is the first agent that we have seen that has done it. And currently our recommendations remain empiric, although we are trying to move to put it on a more scientific basis. The problem is that project was completely set to get started, including with the laboratory phase just before COVID, and everything just fell apart. And I'm trying to get that all pulled together before I retire in January. And diet, yeah. So the hunter-gatherer paleo-based diets are very potent anti-inflammatory diets. How do you say they're very potent anti-inflammatory diets? Heartburn, dysphagia, all those symptoms go away virtually immediately within 1 or 2 or 3 days. That's a lot faster than you would expect to see with the change in physiology. So clearly that's partly the anti-inflammatory. Also things like arthritis and other forms of pain will respond on these diets. And so they clearly have anti-inflammatory properties. They're the opposite of the standard American diet. And I don't think people understand how much sugar and carbohydrates are so bad for inflammation. The standard American diet is about the worst possible diet to be on, and yet we're exporting it to other countries. And the health of anybody on the standard American diet is always going to suffer. But particularly when I started looking after these cases, it was rare for me to have a patient that was considered morbidly obese. Now, unfortunately, it's really common to see patients that are morbidly obese with diabetes mellitus, and also with metabolic syndrome and other issues. And it certainly doesn't help anything, and it certainly doesn't improve treatment options. So I can personally attest to the benefit of paleo-based or hunter-gatherer based on the evolution of our species into mankind. It was a diet that people were on before we had most of all these modern diseases. And I can tell you that for somebody who's suffering from diabetes, metabolic syndrome, different forms of pain, heartburn, whatnot, you'll see responses within 1, 2, 3 days. It's really amazing. So there's several forms of paleo-based diets. There is what's known as keto. There's what's known as carnivore. There's what's known as AIP paleo. That's autoimmune protocol paleo. I think the fastest way, and the whole intention of these diets is to keep your carbohydrate ingestion very, very low, so that your liver runs out of its stored glycogen and starts converting fats to ketones. And so that's it. Once it starts to do that, then it will pull fat out of your fat cells, convert them to ketones for energy, and move off of glucose as the primary energy source. So that's ketosis, and that's basically what you're aiming for. And I think the fastest way to do that now is to do what's known as a carnivore diet, because you don't have to explain it. Carnivore is meat, fish, eggs, and animal products. So dairy, although I would recommend staying away from milk because of the high sugar content of milk, at least at the beginning. And then do that for a week, see how you feel. In the meantime, research about the other paleo diets, because a lot of people get bored on carnivore, but on keto, you can, there are variations of keto, including you have to decide how long your carbohydrates are going to go, for example, but they certainly should be below 50 if you want to lose weight and have benefit. And if you also have diabetes, you want to try to aim even lower than that for daily ingestion of carbohydrates, probably less than 20. If you compare that with the American Diabetic Association, they're still recommending 150. 150 just keeps you diabetic, and it doesn't actually treat the problem. With these diets, you can get off all the drugs if you stick to these diets.
So a lot of us have had large sections of our digestive tracts removed, and like paleo includes a lot of fruits, vegetables, nuts, and seeds, all of which, at least for me, are very difficult to handle. What would you suggest?
Well, you raise a good point, and that is a real problem, and especially it's a real problem not just for patients with PNP that have had major surgery. It's one of the reasons why I've really striven over the years when treating patients to remove as little bowel as possible and keep as much physiology. But that is a problem. You're not quite correct on paleo, and my recommendation is paleo based. That's why I say carnivore or keto. And the reason that they're important is because you're automatically going to be limiting the carbs. And because if there's food on there that you can't tolerate, then you just don't do it. But the food that causes the least reaction is the carnivore diet. The reason that the problem with vegetarian and vegan diets is that they stress, how are you going to get by without eating bread? And on keto, paleo, AIP paleo, you're dropping all of the grains. You're also dropping all the processed oils, and that includes vegetable oil, canola oil, and any processed oil. The only oils you should be looking at would be things like virgin olive oil from a good source, avocado oil, coconut oil.
Okay. Go ahead.
Yeah, let me just say one thing, and that is, if you've had that kind of surgery, and particularly if you had multiple surgeries and stuff rewired, you just have to remember that unfortunately you are now an experiment with an N of 1, and you're going to have to do the experimentation.
I hope our marketing person wrote that down, because I really like that line. That with all of our experience, that resonates as so true. We have to trial and error for each one of us, what's going to work, what's not going to work, and what might cause a blockage. It really is an N of 1. As we start to talk about that diet conversation, it's, as I've listened to it for years, what works for one person may not work for another, and that is just how it is. And I mean, my greatest piece of advice in the diet area, and Martin, to what you were referring to, and the potential blockages, is chew it up good. We eat pretty fast in American culture too, so make sure you chew it up well.
Could you comment on the impact of exercise in addition to the diet recommendations?
Well, you're going to be a little shocked by what I say, but if you go onto these diets, it's optional to exercise. You're still going to lose weight. You're going to have benefit. You may lose a little bit more weight, but these diets are not, they're really, really powerful. And I'm very disappointed that traditional medicine has chosen not to look at these.
Yeah, just fascinating.
Could I?
Yeah, go ahead.
Just say one thing, but Dr. Logie, there would be other reasons to still have an appropriate exercise program. I mean, weight loss wouldn't be the only goal, so I mean, I exercise for a lot of other reasons. In fact, I'm unsuccessful using it for weight loss, but it does help with many other issues in my life. So just wanted to
Well, a
throw.
lot of people get on an exercise, but I'm just telling you that it's not necessary to have the benefit, because there are people who, for example, just weigh too much. Their joints are not
Sure.
working. And so they are going to get benefit without a regimen of exercise. Also, personally, I find exercise is boring. And so I'm much happier going for a walk with my little dog or doing woodworking in my shop and lifting up slabs and moving things around. But that's me.
Mhm. Have you had any experience, or are you familiar with the how do I say this? Fenbendazole protocol by Joe Tippin?
I think it's dangerous.
Okay.
I've never used it, but the reason I never used it was it made no sense to me.
Okay, thank you. Also on Saturday, you talked a little bit about the chemo agent that you shifted to when you perform HIPEC. Could you talk a little bit about that? And you'd mentioned that you've shifted away from mitomycin C, and tell the group why that is maybe has more side effects for patients.
Oh, mitomycin C is an evil drug. The reason I started with mitomycin C many years ago is because it was from Japan, the only drug that was published in association with heated intraperitoneal chemotherapy perfusion. So it made it easier to take it through an IRB. But after years of using it, I was working with a PharmD. That was one of the results of the research that we did. We identified that mitomycin C needs to be activated. There's a specific sequence of enzymes, a couple of which are critical. And in one of the critical ones, we identified that there was a very common base pair mutation, such that someone with that mutation, it was about 25 to 30% of patients, mitomycin would not be activated, and therefore mitomycin would not work. And so once we had done, that was, I think around the year 2000, we published that, I don't remember. But at that time, I was trying to get our laboratory to measure it. It was a very straightforward PCR test, and I couldn't get our clinical lab to do it. But it became very obvious to me that some patients were not necessarily respond to mitomycin. They were still having all the side effects. And so I needed to find an agent to replace them, particularly if I could identify that mitomycin was not going to be effective for them. And that led me to initially change for mesothelioma and ovarian cancer to carboplatin. And there are a number of reasons for doing that. And then after a few years, I basically just wholesale moved my chemotherapy to carboplatin for all indications, including colon and PMP and other entities. The reason for choosing carboplatin is that it's much less toxic to the lining surface of the peritoneal cavity. So you don't get the intense peritonitis or inflammatory reaction from mitomycin C. And you can even see the differences on the package labeling. On mitomycin C, they say, you know, if you get extravasation into soft tissue, that's a real problem. You've got to deal with it. With some of the other platinums, they still can cause problems with extravasation. Carbo does not. So we're basically dealing with a kinder, gentler agent, but one which at the same time has the same effect, especially when you have cells in direct contact with a carbo, then it's metabolized to the base molecule that's active for all of the platinums. So in a test tube, you can use any of the platinums interchangeably. So obviously, not in a test tube, I'm going to use the platinum that is generic, inexpensive, and has the fewest complications, and gives me a good high concentration and reduces all of the risks and side effects. And it has done that. So now with our combination ARAS or early recovery after surgery protocols, we've been able to bring our hospital stay down for cytoreductive surgery and HIPEC to a median of 4 days,
Wow. That's amazing.
which I think is the best in the world.
I've
Or at
never
least
heard
it
anything
does.
like it. That's remarkable. It really is.
Yeah, I thought we'd hit a ceiling a number of years back.
Paul, did you have a question?
Yeah, the issues with the mitomycin C, you may have said this and it may have just gone right by me, but what are the side effects that you see with mitomycin C?
Well, I'm not using it anymore because I hated the drug. And what
No,
I
no,
saw,
I understand that, but what typically would be the
stop,
side effect?
stop, I'll tell you. Mainly we received peritonitis. It's also a very nasty drug. You've got to be very careful with dosing. You can get a fatal neutropenias, thrombocytopenias. You can get grade 4 becoming rapidly grade 5, which is death toxicity if you're not very, very careful with mitomycin C. And it also causes, because of the inflammatory response, it causes really intense scarring throughout the entire abdominal pelvic cavity, making it really difficult to go back again. And so I don't have that problem with carbo. I've been treating for adhesions for years using an agent to prevent adhesions. And that combination makes a huge difference when I go back to operate. If someone's had mitomycin, typically you can't go back in with a laparoscope. In my patients after carbo and treating for adhesions, you can typically get in with a laparoscope.
Right, and to continue that question, is there a higher or lower reoccurrence of PMP with either one of the two drugs?
I didn't see it. When I changed, what I did initially was to summarize the data for, I forget how long it was, maybe a couple, 2-3 years. And our overall outcomes and mortality were actually better with the carbo. And now, because they were done at different times, then there was not, one did act as a control for the other. So it was observations, but I was very gratified to see that we were not having mortality very early on.
Thank you.
I mean, in my hands, in my experience, using so many, I'm the one who kind of spread mitomycin around to other centers. And I've been trying to tell people for a number of years that, hey, I've abandoned this drug, and here are the reasons why I've abandoned this drug. So
is there a when it comes to cytoreduction and PMP and HIPEC, is there a gold standard as to a drug that is used?
no, there are people that no. And I don't know how important that is. I mean, people have not agreed to standardize because you really need to do a certain amount of work to do that. And I don't know how different some of the regimens are. Really, it comes down to patient selection. How you do the surgery, I think, is important, and making sure that people are appropriately selected. I see a lot of people that seem to me to be inclined to use higher doses of drugs or possibly multiple drugs. And so they're skirting with morbidity and mortality. I find that if you, and the data is very clear, the fewer complications you have, the better your long-term effect and influence. And certainly if you start having patients die, that's going to mitigate a lot of benefit.
Thank you.
Are there other physicians who are using carboplatin besides you that you know of?
Yeah, some of the GYN oncology people have used it because I got the protocol from Wake Forest. They took my protocol for testing and used it for testing carbo. So that's where I took my initial dosing schemes. And I have discussed how to use it with other people. How extensively they have adapted that, I don't know. One of the problems is that with COVID, we've all stopped going to meetings for the better part of 2 years. And that's typically where I get to exchange a lot of information. And not Zoom meetings for the most part. I mean, you're talking, 2, 3, 4, 5 day meetings in person.
One of the other topics you educated us on Saturday is, we tend to use the words LAM and low grade interchangeably, and you were clear that there is a difference. Could you explain the difference to us again?
Yeah, well, in LAM, what you're doing is you're describing a low-grade appendix neoplasm that it doesn't have enough characteristics to really call it a cancer. It's called low-grade adenomucinosis. And it's categorized more as a neoplasm, and whether it's going to behave in a malignant fashion or a benign fashion. I think it tends to behave in a somewhat more benign fashion, because even when they're perforated and mucin has spread from the lesions, unless there's cells associated with that, we're seeing almost none basically recur. And I know there are people out there that would do, right hemicolectomy. I've got some colleagues that do laparoscopic HIPEC. Our survival is running 100%. We're typically not having to do surgery. Part of the reason we're not doing surgery as well is we don't do follow-up laparoscopic surgery, because we have our own protocol for doing MR here. I developed that with an MRI dedicated radiologist a number of years ago. Our protocol is done in half the time of the regular abdominal pelvic protocols, but it provides us with sequences that have a lot more information for what I'm looking for. What a CT does not give. A CT gives people radiation. I don't like CT. The MRI gives me a lot more information about the actual PMP. May not make a difference in management for high volume disease, but certainly for surgical management and for low volume disease, the MRI is not only better, but it's far more sensitive than a CT. And it gives me information about the cellularity of the PMP, something that you kind of have to infer or guess, and it's usually not a very accurate guess with CT.
And I think you had mentioned a PET scan would not be a useful tool.
Not for low-grade PMP. For patients that have signet cell, particularly with recurrences, it can be useful, but for disease that's confined to the peritoneal cavity, PET scanning is of limited utility. And for PMP, it's of virtually no utility, in my opinion.
We had a question come up. A
Spock
patient
asking me what's going on.
Oh, hi, Spock.
All right, go ahead.
Yeah, no, Spock's welcome anytime.
Well, that's what he's saying.
A situation where high-grade disease, systemic chemo regimen prior to CRS HIPEC, successful CRS HIPEC, clear margins. Is there a protocol on whether or not systemic chemo would be recommended post CRS HIPEC?
Yeah, originally we didn't. We did a lot of work looking at signet cell and treatment. And I've become convinced that after that regimen, if you feel that that's been successful, you want to go on to some kind of a maintenance regimen. And that may just be Xeloda for some period of time, rather than the full systemic chemotherapy. But we think that's of value because these high-grade tumors can recur sometimes fairly regularly and sometimes quickly. And so I think that from what we have seen, it makes sense to consider some form of maintenance therapy.
Okay, thank you.
Mm-hmm.
And we've talked a little bit about how as patients, when we go through our surgeries and we leave the hospital, we really don't get an instruction booklet on, what to eat, what to do, how, sometimes we're not sure how often we should be monitored. What advice can you give to patients for, just long-term, monitoring and a long-term regimen post-surgery?
Well, we don't have a booklet. Basically, we individualize, but one of the big things, at least before, and I don't know if Holly came onto this call or not, but Holly is my nurse practitioner, and she would round with me on a regular basis and with the residents, but typically would stay behind and talk to the patient, particularly as we're getting closer to discharge, so that they have information, their questions are answered again. And she can address all of those issues, and they have a way to contact her. And then she's usually going to be the first post-operative contact. And if everything is okay, then we set up a follow-up period, which rapidly becomes longer and longer.
Okay, thank you. You're reminding me, and I meant to do this earlier. Could we get a show of hands as to how many of Dr. Logie's patients are attending today? Wow. Wow.
There's a couple folks for sure.
Yes, you have fans. Much appreciated. So do any of Dr. Logie's patients want to ask a specific question?
That sword behind me came from a patient.
Oh, really?
Really?
Oh my.
Because I always wore a sword on my lapel. So I actually received a couple of swords over the years from patients.
Very thoughtful.
Adele, I'm not one of Dr. Logie's patients, but Dr. Logie, you mentioned the ERES protocol earlier. Some of our participants won't know what that is. Could you go over that briefly, please?
It's a protocol, enhanced recovery after surgery. And what we began to realize is that the side effects from it's called enhanced recovery after surgery. The reason that I wanted to pick it up was to get rid of narcotics before, during, and after surgery. And we've been successful in doing that almost universally. The only patients we cannot stop narcotics or cannot not use narcotics in are patients that unfortunately were put on narcotics before they came for surgery. And the problem with narcotics is it rapidly decreases your pain threshold. So there was an article in Science, it was a review article, I don't know, maybe a few years ago. And what they said is that on patients who were taking narcotics compared to a control population, you can put your hand in ice water. It's a standardized test. And I think you can, keep your hand in there about a minute and a half, maybe 2 minutes. I don't remember the final time. The time for patients on narcotics was 15 seconds. So the narcotics also cause, now that we're not using narcotics, now to replace the narcotics, we use a whole bunch of agents. We had to work together with anesthesia, the residents, nursing. It's not simple to do, but the results are absolutely striking. And that's one of the reasons why we're getting people out of hospital in 4 days. We're not seeing the narcotic side effects, huge narcotic side effects that, I can't believe it. For years, we used narcotics as the only standard for post-operative pain control. And I guess we just got used to all of the complications. What are the complications there? Obviously, things like you get mental clouding. It can make it difficult to breathe. You get a lot of headaches. You get GI side effects, which can be very severe, and basically just on and on and on. So dropping that, as I said, it's not simple. We've actually done at least 3 national, international presentations on ERES in HIPEC, and it should have been published, but the resident that wrote it up finished and went into her fellowship, and then didn't keep her promise to finish up the paper. So I don't know if we're going to be able to get that into print. Other questions?
Well, I guess one follow-up to that, I it might be too complicated to explain what you substitute for the narcotics in this forum, but what can you give us just a broad idea of what that would entail? I mean, this is very interesting. I guess I just assumed that narcotics and recovering from this kind of surgery always would go hand in hand because of, you know, how much is done, but I'd be interested in learning a little bit more.
No, we're getting better pain control. People are getting out much faster than on narcotics. We work in concert with anesthesia, so they get certain medications. We use IV Tylenol a lot. It's much more effective than oral or rectal administration, although the hospital gives pushback on that. Sorry, are we still talking to each other?
Yes.
Yes.
Yeah, okay, somebody's trying to reach me on the phone. And so we use a variety of infusions, and then the devil's in the details because we monitor those and decrease those post-operatively and get started fairly early on oral regimens. We find that Mobic or meloxicam is a very, very effective oral agent, probably more effective in my experience than narcotics like oxycodone. And so basically what you do is replace that with a variety of different agents that act in different ways. So for example, before surgery in the operating room, our anesthesiologist will give people magnesium because magnesium is a very good agent for pain.
You may have partially answered this question, but what can you offer for pain control for someone that can't take muscle relaxers, antidepressants, non-steroid, anti-inflammatories?
Well, that's a broad list. I typically am not recommending antidepressants. I'm typically not recommending muscle relax. I mean, something to substitute for some of these things, particularly if you're talking about nausea. Or muscle tension that results in pain. But we've been using Ativan or lorazepam for years and years and years. And in our practice, it's been safe and it's generally been effective. I don't know why, but the internists the last few years have come down hard on lorazepam, but we found it to be very, very helpful as adjunct treatment. And then Mobic, which is a non-steroidal anti-inflammatory, but we've not seen the side effects of other non-steroidal anti-inflammatories typically with Mobic. I think it's because it's a better molecule. The SH group is hidden within the molecule, so you don't get some of the side effects you can see with other non-steroidals, and we haven't had kidney issues with it. So by far, that's for pain. That certainly is a backbone. For people that can't do that, then you add an adjunctive agent, say like Ativan, so that people are calmer, because it obviously helps to release anxiety and stress and do it safely. And then you just have to use other agents, and sometimes you need to use more than one. For those of you who have had bad problems with nausea, you understand that you want to get that treated quickly. And you may need multiple agents to do it effectively.
You said that Mobic was a better NSAID than the others. Does it cause less stomach irritation?
It occasionally, but we've not seen it. I mean, partly that's because it's a much smaller dose. I think small pills can be taken once or twice a day. The top dose for adults is 30 milligrams. That can be taken 15 milligrams twice a day, or just 30 milligrams once a day. I find a lot of people, if we're now getting away from the acute surgical period, they're fine with 15. I had a young girl who was released home, and for some reason she didn't fill her prescription for Mobic. She went to her emergency room. They gave her narcotics. The surgeon called me and said he was going to operate on her because she was in so much pain. I said, you know what? Just send her down to me. She came down to me. We got her back on the Mobic, and she was home the next day. All the pain gone. Yeah, so it can be a very dramatic agent. A patient of mine, John Kennedy, who lives out in Depot Bay, Oregon, is a pharmacist. And he was the one who researched Mobic and gave me the information many, many years ago. And I'm very grateful to John, because it has been a very, very effective medicine for our patients.
Is it prescription?
Yes.
Okay.
But I think it's probably safer than aspirin. And I don't think aspirin is as safe as we think it is.
Well, thank you. Patients are taking turmeric, and maybe turmeric does or doesn't make a difference, but the question is, what tests are used to monitor C-reactive protein, tumor markers?
Yeah, we do that. The other is obviously MRI monitoring, because we're following their disease. And so the best that you can hope for with persistent or recurrent PMP is for that disease to be stable, and preferably in a patient who is not having symptoms and is having good quality of life. So that's where I'm hopeful that this could work well for a long time for people, because then you don't have to be waiting for symptoms to occur and then reinitiating surgery. Hopefully you can hold surgery or an additional surgery off for a long period of time. Because typically after the first comprehensive surgery, you can't go back and do that again. It actually makes no sense. So we typically, when we're following patients with PMP, if they start to have symptoms, we try to identify specifically where anatomically are we getting symptoms? What are we getting symptoms from? Is it from pressure? Is it from obstruction? And then if we're thinking about surgery, we want to do a targeted surgery, get the most bang for buck that we can, preferably a small incision, get out, and then presumably and hopefully the patient is now improved, and that's when we want to get them onto turmeric and hopefully stabilize that disease further.
Thank you. And
Yes.
back to the MRI, could you comment a little bit about the expertise it takes to accurately read an MRI versus a CT?
It's a huge learning curve. Took me a long time to be comfortable looking at MRI, and I'm still not comfortable looking at certain sequences. So I rely upon radiologists that I work with. But what I do for clinics after a patient's been scanned, I go over to radiology and I sit down with the radiologist so that they have the patient information, my information, I have their information, and we put it together. So it's not a black box interpretation. And that makes quite a difference. That way I'm familiar with, the radiologist. I go to the radiologist I'm comfortable with. They're comfortable working with me. We set it up as a program. So we use special sequences for scanning that particularly work for pseudomyxoma peritonei.
Thank you. What advice can you give patients that experience bowel obstructions on a regular basis?
Well, what's a regular basis?
More
Once
than
a
once?
year, 6 times a year, twice a year?
2 to 6 times a year.
2 to 6 times a year. We can sometimes see that in people that with PMP, unless you're looking at dilated bowel, specific area of obstruction that can be mildly dilated, our experience has been that most, not all, but most of those people will settle down. If you start to look at, say, you've got something going on 6 times a year, you should be able to identify anatomically what's going on and then decide whether it makes sense to do further surgery, because I'm sure people know particularly if they've had multiple surgeries, there's more and more risk each time you operate. And you don't want to take a situation that's not great, but not terrible, and turn it into a terrible situation by having a complication, like fistula or sepsis, or, I've learned the hard way, you can make a bad situation worse.
Thank you.
Can I-
Have you ever used antibiotics as, in treating PMP patients prior
No.
to surgery? Okay.
I don't believe that research. I know the physician very well.
Mhm. Okay, yeah, we're recalling a study along those lines, and I think some centers, have given their patients antibiotics just prior to surgery in the hopes of making the cytoreductive surgery easier.
I don't think that's going to make the cytoreductive surgery much easier. Cytoreductive surgery takes a lot of experience, and it mostly is very difficult. When it's not difficult, that's great, and you get everything done, because it's very hard to get to plan A. Plan A is the plan I said, where you do cytoreductive surgery, remove all visible disease, run HIPEC. And plan A is when all visible disease is removed. And that, I wish it was successful more often. It's because typically patients are presenting with more advanced disease. And so ultimately, you're going to look at persistent or recurrent disease in, unfortunately, the majority of patients. That's one of the reasons why we have spent so many years trying to look at what we can do in terms of medical management, and then specific strategies for managing certain types of symptoms and problems, and trying to our goal is to maintain good quality of life, or to improve poor quality of life. And so that's always, when we're making decisions, whether it's surgery or medicine or chemotherapy, the key is, what is the impact on quality of life? If you improve or maintain good quality of life, then guess what? All kinds of options open up, including alternative treatment options, but survival is automatically improved.
Absolutely.
Um,
In
Yeah.
what situation would a patient not be eligible for HIPEC, or also not be eligible for CRS and HIPEC?
Well, there are lots of reasons. The most common reason is if you've got so much disease that you can't safely remove it. And there you're looking at typically bulky disease. It doesn't have to be bulky if you're talking about high-grade disease like signet cells. So with signet cells, what does not show up very well on scanning very often is disease involving the small bowel mesentery. And if there's extensive involvement of that, you basically need to back away. There are instances where you can do limited cytoreductive surgery and legitimately run a HIPEC. And that is for patients with symptomatic malignant ascites, because you can make the ascites go away very quickly, basically overnight. And it's effective for about 80% of patients. So that's a palliative use of cytoreductive surgery. Some people are very confused when we talk about doing it that way. But if you're using as primary treatment, then preferably you're looking at finite disease, a reasonable, what I would call a reasonable operation, and the goal achievable of removing all gross visible disease, and aligning with all of those factors. Because I was young and nobody was telling me how to do this for a long time. We did a lot of big surgeries, but what I've learned is to be more selective, and then I know what I can do when I get in there and do it safely. And I don't try to do crazy. What I try to do is not burn bridges. And then if we find that the strategy that we were going to do is not going to be our best strategy, then by the time I come out of the operating room and I'm talking with a family, I've already got several strategies in mind, and referrals and whatnot based on what we've found. So I think it's always important to have a plan. And if plan A doesn't work, you don't just stop there. You really need to say, okay, here's plan B, here's plan C, here's plan D. And when to use plan B, C, and D, and what order, and what preference, and all that kind of stuff.
And Dr. Logie, I think this discussion of goals is really an important one too. And I mean, I can tell you, it's very, very hard for us as patients, as I'm sure you understand, right, to accept kind of that goal that we're going to live life with disease for the rest of our lives. And that's very scary to us. But that said, I mean, you've seen it, we have seen it, and patients have great lives with disease. It doesn't mean that that life has to be compromised. I mean, certainly all of our bodies are going to get older. We're always going to have to adjust to that. But I mean, really, the goal of living with stable disease is not a bad thing. But it's just scary. I think emotionally, it's really hard to accept that as the goal.
Well, you do have some people that have really, really advanced and very symptomatic disease, and surgery is not going to improve that. That's a very difficult situation. However, in our situation, we see a lot of patients that either have had surgery elsewhere or who, for whatever reason, either had persistent or recurrent disease. And then if they had limited surgery elsewhere and a candidate for the full Monty, then we will do that. But if they have disease that persists after that kind of a strategy or is recurrent, then we go into more of a control mode. And what we're doing then is to follow people, try to figure out what could slow down or stabilize the disease medically. That may include systemic chemotherapy or stuff like Xeloda. Certainly now for low-grade PMP, I think the turmeric is making a big, big difference. And then as patients start to develop symptoms, we're identifying where symptoms might occur on MRI before someone's symptomatic, and we follow them through and then make a decision. Okay, is it now time to do some surgery? Our median survival is over 10 years for patients with persistent or recurrent disease. And to be in the group with removing all of the gross visible disease, or attempt to remove all the gross visible disease, the actual difference in survival was only, shockingly to me, was only maybe 2 or 3 years. So we have a lot of patients that we see on a weekly basis that we're following, and clearly, if they're starting to become symptomatic and there's problems, we need to review what can be done. At some point in time, you may run out of problems, but if you're careful and analyzing quality of life, and you address some of these options and use targeted cytoreductive surgery, as I say, we're not seeing that much difference in outcome for patients that have persistent disease or recurrent disease as just, haven't been successful with upfront treatment. Kind of shocking, and it sort of goes against the narrative.
Well, I mean, but to your point, we're still seeing great life in people, regardless of what the goal is, and so tons of reason to be hopeful for sure.
Yeah, pseudomyxoma is a funny disease, and sometimes what I have to look for is what is the biology of this. They don't always act like what you see under the microscope, and so for when I see patients back with stuff going on, I'm really trying to figure out what's the biology in this particular case. Can we be a little bit more laid back? Do we need to be initiating some other form of therapy? Do we need to change the timing of follow-up? All those kinds of things come in. Excuse me.
Should patients on watch and wait be monitored more frequently?
I don't understand what watch and wait it means.
That means they have disease, but they, for whatever reason, it's not enough to have CRS HIPEC. They know they have disease, and they're just getting monitored.
And sometimes it's folks who just got that local right hemicolectomy, and now they're watching and waiting, right? I think, that's all also part of the watch and wait group.
Well, because they're completely different.
Mm-hmm.
One is that if you've got disease, low volume disease, then the reasons to watch and wait there would be if you have somebody that has excessive morbidity or potential for morbidity, have contraindications to surgery. So I'm really not keen to take somebody who weighs 400 pounds to surgery. We're probably not going to get our goal achieved. We're going to have potentially all kinds of problems and issues. And so a improvement in nutrition and diet and maybe an anti-inflammatory approach might actually work better, because the mortality from the other conditions is probably worse than that for low-grade PMP. If you're talking about the appendix neoplasms that people are following, I think they just get people too excited. I see appendix neoplasm patients for second opinion from all over the place, and we define the parameters where there's low risk. It's very difficult to define no risk. But in the patients over the last few years that I've defined as low risk, that would be mucin but no cellularity, things like LAM tumors, we're not seeing recurrence. So we're not offering surgery. We follow them with MRI. If there are no surprises after the first MRI, which is usually at 4 to 6 months, then the next one is usually at a year. And if everything is stable, we'll run an MRI out annually. I've actually cut my intervals for following patients from when I was a young surgeon. So it's not unusual. Once a patient is relatively stable, even with disease, we don't need to see them several times a year unless there's something that has changed. We'll see them on an annual basis. Sometimes even more than that. I mean, a more interval, like a 2-year basis.
Thank you. Wayne, did you have a question?
Yeah, thanks. Hello, everyone. And thank you, Dr. Logie, for agreeing to join the Tuesday group, because I couldn't make the Sunday group at 3 a.m. on the other side of the globe. Trust you understand, but thank you.
Sure.
I'm just wondering, you when you were mentioning about the different diets and cutting carbs and so forth, how do you manage your patients with TPN in the immediate post-operative period? Do you adjust that from what the dietitians would normally set up in, say, other centers?
I'm getting patients out of hospital in 4 days. They don't need TPN. And the patients that are malnourished, okay, TPN doesn't work, particularly in more advanced PMP, because they have a chronic inflammatory response. So sometimes what you have to do is sort of temporize, improve things like albumin over in hospital for a day or two, improve hemoglobin from chronic anemia of chronic disease. And then if you think that you can improve their situation with surgery, do that. Those patients may get supported with TPN after, if their nutrition was bad, but unfortunately, TPN does not work very well for patients with advanced PMP that are suffering chronic nutritional issues.
Mm-hmm.
And no, I wouldn't listen to the dietitians other than for standard recommendations for standard therapy. Unfortunately, they're all here pushing the variation of the standard American diet, which, as I said, I don't think it works very well.
Right. And just you mentioned the acellular mucinous type of PMP. So what is producing such copious mucus when there's no cells visible in the peritoneal cavity?
Oh, a rupture of some sort. So it's spilled from the inside of so it's usually associated with a perforation. But surprisingly, if the mucin is no cells, cytology shows no cells, those patients do fine. We just follow them with MR and document that they're doing okay. It's kind of shocking, but there you go.
So you're saying that they're actually not cells that are ectopic, in other words, outside the appendix, is they're
correct.
They sort of
the assumption was that acellular meant, well, you just didn't find some cells, but I've had report after report, patient after patient, where they see acellular mucin. It comes down to the question of why is so much mucin made. There's 2 different kinds of mucin in PMP, but PMP with acellular cytology is not PMP. You have to have implanted cells that grow on the surface. That's PMP. Anything else is not.
Yeah. Okay. Well, that's what I had in my myocytic tap. Showed some strips of columnar epithelial cells, and I was wondering afterwards. You know, unlike other cancers, which seem to rely on neovascularization and stuff, new vessel growth to support them, and how are they metabolically surviving? Because you know, quite often you're not seeing necrotic cells; they're actually viable. There's a strip of 5 or 6 joined together, as you know, not uncommonly in PMP. So, do you think they're picking up? Are they living mainly anaerobically? Are they living off the sugars surround the glycoproteins surrounding the mucin? Those long
Stop for a second.
chains?
So,
Yeah.
if you're a woman and you had ovaries, then the peritoneal cavity is a place where those kinds of cells can survive. It's not a hostile environment. I mean, if we ramp up inflammation, we could perhaps make it a little bit more hostile. So I can't comment on your specific case because I don't accept outside pathology reports. I always review outside cases with my own pathologist. So I'm not sure what you're talking about. You could be at risk if they did identify neoplastic cells for the development of PMP. But if everything looks okay, if they didn't see any obvious implants at the time of surgery, then my approach would be, in fact, to do kind of a watch and wait approach, because not everybody develops disease. I've had a number of patients who were operated on for PMP, selected places. When we scanned them, they looked okay. In theory, they were very high risk to recur and progress. And I've got a number of those patients I haven't had to do anything with for scores of years. So, so we would follow with MR because it's much more sensitive than CT. And then if we have a question about anything that's going on, we would want to take a look, because if we catch something early on MR and it turns out to be real, we should be able to eradicate that disease.
And what are you? Sorry, you may have answered this last Saturday or on the weekend, but what are you combining immunotherapy or other therapies, metabolic therapies? Well, I mean, you mentioned certainly earlier on, I heard about the diet, paleo diets and so forth, and low carbs. But yeah, have you been doing many trials with new, combinatorial? In other words, debulking a lot of the tumor to give the T cells a chance from not getting burnt out so quickly and that kind of thing.
I don't think you're going to see the same benefit for immunotherapy as we're seeing with things like melanoma, Merkel cell. I used to specialize in treating melanoma in the days when we didn't have that. I actually was the principal investigator for several immune trials looking at melanoma. And there we were injecting melanoma cell derived from cell lines that had been killed, basically as a vaccine. We saw activity in over 25% of patients, which meant who had a very high risk or who in fact had metastatic disease. The FDA wouldn't allow it to go through because they said it had to be compared with a chemotherapy agent. The chemotherapy agents at that time for melanoma were virtually worthless and had a lot of side effects. So that was very disappointing to see that you had something that you could use on trial and then you couldn't get it through the FDA. So I'm sorry, I digress. But the immunotherapies you're talking about now that are making such a big difference for some of these diseases, and including for mesothelioma, we certainly see it work there. I think particularly for low-grade PMP, not likely to be helpful. That would have to be addressed in a trial. For high-grade signet cells, if you look at other high-grade GI malignancies, and you do the testing, above 5% will have markers that suggest that they should be treated with immunotherapy. And in that subset of patients, you're looking at about an 80% response rate, which is really amazing. The problem is 5% isn't a lot of people.
And can I ask, can you explain what, those 5%,
Yeah, you're looking at high mutation rates. And so that makes
of
it
what
much more
specific
likely.
genes?
No, you're looking at multiple mutation rates through multiple high mutation rates throughout the genome. That's tested for. And you can also look at PD-1 and PD-L1 receptors, and then make some predictions for the or not for there. It's disappointing that for high grade disease, probably only about 5% of patients are likely to respond to immunotherapy. So it's unlike melanoma. And melanoma and Merkel cells and things like mesothelioma, they're very good. For melanoma, it's almost a miracle and it works, except that you do get sometimes severe autoimmune side effects. But I don't see a lot of promise right now for immunotherapy for PMP. What time is it there?
Here it's 10 to 9 in the morning, and anyway,
just curious.
It's the sun shining through
I
this way.
I treated some patients from Australia, and one of them rung me up, and for me it was the middle of the night. I can't remember what time it was for Andrew. Anyway, that was a while back.
Yeah,
and Dr. Logie, just so you know, Holly's here. She jumped on a little bit ago.
Oh, well, pull her in.
Hi, Holly.
She's shy.
Well, we're glad you're here, Holly. We are going to do our quick commercial, and then we'll be right back with some remaining questions.
Well, I have one question real quick, Dr. Logie.
Okay.
This empirical experience with the turmeric and curcumin, about-ish how many patients are we talking about? Is that 50 patients, 100 patients?
That's one of the problems I got right now. I've got to go back, and one of the things I wanted to do before I left was to do QA/QI and go back and just get a better number over the last 3 years, because obviously some patients do repeat. So I'm not sure in total how many there would be, but I'm pretty sure it would fall into scores. I don't know if Holly's there, she could comment.
Well, again, it really is not a question about, the efficacy and the statements you're making, because I mean, just as a reminder for folks, at least when I got involved 16 years ago, Dr. Logie was one of the top names and remains truly be one of the top names within our world. So a huge amount of experience. Dr. Logie, were you at Aspen? I want to say that was the first time I saw you talk at Aspen, like 16 years ago. Does that ring a bell?
Yes.
Yeah.
I remember I went fly fishing. It was the middle of winter, and you could watch the private jets landing at the Aspen airport.
Yes.
It was weird.
Aspen is something else for sure. Absolutely. Well, we will take a commercial break real quick here. Let me get my screens set up. And again, thanks everyone for being here for such a great presentation. We appreciate all of you being here. Again, we're sorry you have to be here, but we're glad you found us. And we hope that all of you are taking advantage of the different free services that we offer at PMP Pals. All of these different programs that you see above are all free of charge. And these are just different ways for us to connect with you, help educate you, and most importantly, support you emotionally through this process. All of us that have been doing this for many, many years believe that the emotional journey is actually more difficult than the physical journey, as difficult as that is. So we provide all these different ways to stay connected with the network of patients and caregivers, and we want you to feel supported, and we'd encourage you take advantage of them. We do send these out proactively to the best of our ability, but there's quite a few patients, and so we do miss things. So please, this is a time for you to practice asking for help, and that can be difficult for us, but now is definitely a time in your life to be doing that. So I hope you'll look at these different email addresses and reach out to them and ask for support and help. The other thing I would ask you to remember is that this is all donations run. So you can go to pmppals.net and you can make a donation through PayPal there. We hope you'll do that. Another quick way to do it and support us is to register PMP Pals as the nonprofit that you support. And so we are a IRS designated 501c3. And so those donations are tax deductible to the fullest extent of the law. But if you register us, then 0.5% of your purchases will go to us as a donation. And that money does add up for sure. So we hope you'll think of that and pay it forward like we're doing today. Again, the board members, we don't make money. This costs each of us money. And so we hope you'll do your part and help pay this forward so other patients are supported into the future. And then finally, please do stay connected with us. You can always find us on the internet at pmppals.net, on Facebook at the PMP Pals Network, and on Instagram at PMP_Pals. And I don't know, I just made a donation to PMP Pals because I went to Amazon, bought my bottle of turmeric for sure. So I'm pretty sure other people will probably be going to Amazon before the day's over and putting in their order. So really an amazing presentation. But yeah, again, thanks to everyone for being here, and especially Dr. Logie. We may have a couple more questions.
We just have a few questions before we're at time. Dr. Logie, do you have any opinion on patients taking Ensure? So that is something that patients commonly take after surgery.
Yes, I do.
Okay.
I don't like it. Too much sugar in it.
Mm-hmm.
Now, there are different formulations of Ensure. Basically, I don't like any of the commercial supplements very well. Now, I do have a comment, a suggestion, and that is Holly's microphone is not working, but she's going to continue as my nurse practitioner. She's been managing patients with me for years. I think it would be very helpful if you had her on sometime in the new year.
You're in, Holly. You're in. Plan on it.
Is she in? Can she comment?
Absolutely.
No, thank you. Very, very generous. I mean, we don't want to make light of how we appreciate the generous giving of your time and your expertise. So much appreciated. And we definitely would love to have Holly.
Adele, may I ask a follow-up question? I think that one of the reasons that there's a line of questions in the chat about Ensure or those supplements is several of the patients have said their issue is not losing weight. You know, when you were talking about a paleo type diet, their desire right now is to regain some of the weight that they've lost, and they're kind of struggling. And I think that the Ensure came up in that context. Do you have any suggestions, Dr. Logie?
Yeah, I just don't think it works very well. Honestly, I mean, if your digestion is basically returning to normal, what you're doing is you're just chugging a lot of sugar as far as I'm concerned. Some of them have a somewhat higher protein value, but still the ratio really is not that good. The thing about the other diets I'm talking about is that they're not diets to lose weight on. You can be healthy on those diets. You can and will equilibrate on those diets. This notion that you're going to eat a bunch of sugar and get healthy, it just doesn't work. That's my opinion.
I have a question also. It may have been answered before, but if so, I missed it. The idea of ketosis, is there something miraculous about ketosis, or is it simply that it indicates that you are not overeating in the way of carbohydrates?
No, there's something miraculous about ketosis, and the overall diet has such a strong anti-inflammatory effect. It's amazing when you take carbohydrates out of the mix. So the liver has shifted metabolism from glucose preferentially to ketones. By taking the ketones, you're now taking fat out of fat cells and breaking that down and sending that to the rest of your body, including your brain. Your brain needs a little bit of glucose, but your liver can take care of that even when it's in ketosis.
What about your kidneys? Is there not a damage with kidneys with ketosis?
No, that's nonsense.
Interesting, because I had that. I believe that as well. Okay.
Yeah.
Good.
No, that's there are a lot of myths about ketosis. Go to the best place to get information on the keto diet or carnivore diet is at a place called letstruck.com, LETS truck, TRUCK.com. It's a site for health. Well, more than health. You go to the university tab, and then that'll direct you to a lot of information. Some of it free, some very reasonable courses, and just a huge amount of information. A lot of it from a fellow by the name of Kevin Rutherford, R-U-T-H-E-R, Ford, F-O-R-D. And he also does a show on Sirius XM Radio 146 from 10 until 1. That would be Central Time. I try to listen to him, basically keep up, because he is just an absolute fount of information for these diets and health related effects. He's basically a natural practitioner, nutritionist.
Good resources. Yeah, thank you. We talked about that on Saturday. So good resources.
Yeah. I think that's the best resource. I mean, you can go and find books and whatnot on all of these topics, but if you want to have it distilled into useful information that you can start to use right away and definitive answers to a lot of questions, that's a great place to go.
Thank you.
Yeah.
A question came in, patient, do you find it unusual that the omentum was removed with the initial thought that it was covered with cancer, but it turned out after pathology it wasn't, it was just mucin? Would the omentum still have been removed?
Well, you can't tell how cellular mucin is just to look at it. So you can have a lot of mucin, but in some cases it can be acellular. The only way you would know would be to look at all of it under the microscope.
Okay, thank you. Again, what is the Sirius XM channel?
I believe it's 146. If not,
Okay.
It's right next door.
All right.
It's Road Dog Trucking.
Okay.
And the reason I recommend that is because this site is dedicated to the health of truckers whose health is terrible, especially for things like obesity, metabolic syndrome, heart disease. And it's amazing the beneficial impacts on this group of people.
Thank you. Well,
Yep.
One final wrap-up question, and that's, just given all of your years of experience, what's the best advice you can give to us patients?
Well, as I said, I think it's understanding your options. You need to have those discussions. And I think the other thing is not to put too fine a point on pencil, but you talk about people being anxious with wait and watch, or watch and wait. And I think that one of my jobs is to put everything into context and basically let you know you're not being followed by an ambulance with a siren and lights blaring. We've got some options, and here's our plan A, here's our plan B, this is when we would go to plan B, here's our plan C, here's our unintended sort of plan. And then to point out to my PMP patients that our patients typically live for many years, and the final number of years isn't that different than the group that had ideal surgery, cytoreductive surgery, and HIPEC at the very beginning, which is a number that still kind of floors me. So, it is what it is in that context, and that's why I say, I mean, Holly and I have been following patients for a long time, and we really just try to identify problems and then see what we can do to basically fix them and just keep on our journey.
Thank you. Well, we are at time. This has been just another wonderful session. We can't thank you enough for your time and responding to all of our questions. And this certainly will be one of our most popular videos. Much, much appreciated.
Dr.
Dr.
Logie.
Logie,
You're welcome.
Oh,
I have a completely unrelated question. Is your dog a Japanese chin?
My dog is a Japanese chin and he comes from a breeder in Oklahoma.
I used to have a Japanese chin and it was my most favorite dog that I ever had. They're wonderful dogs.
Let me show you something. See that?
Yes.
Where is he?
Oh.
You muted.
Yeah, that's his litter box. You see that? So he's litter trained. So if we have really crappy weather, there he is right there.
Oh my gosh, he's adorable.
Yeah, then he doesn't have to go out. This is the easiest. He's easier than a cat because he just walks
Oh.
on the litter. Cats kick it all over the place, and the litter is pine pellets. So, and these breeders got him used to doing that before he came to live with me. It was worth the price of admission, I can tell you. And he's just the cutest, sweetest little companion.
They are the greatest dogs. He's so cute. Thanks for sharing. That made my
You're
day.
very welcome.
Aw.
Yeah, thanks.
Oh, that's fantastic. Well, again,
I guess
Dr.
that's it, right?
That's it. But I do want to take a moment to remind folks, even though we don't give medical advice, we'll do our best to help you identify your different options, and we can certainly refer you to the experts all around the world. We're happy to do that. So thank you all for being part of the PNP House Network. Looking forward, just remember, so on the 18th, this coming Saturday, we are having an ugly sweater celebration. So when we see folks on Saturday, please do wear your ugly Christmas sweaters. We'll look forward to seeing you there. And we are off then until the first of the year, when we'll have a New Year's Day celebration at that point in time. And so we'll look forward to seeing you there. And we will take you up on the offer to have Holly on in 2022 for sure. We will look forward to that as well.
Yes. Thank you, everybody, for being here.
Thanks so much, folks.
Thank
Have
you.
a great day, and we'll see you on Saturday.
Thanks, everybody.
Thank you.
Bye-bye.
Bye-bye.